Hi, everyone, and welcome to the Clinics Review Articles podcast series. I'm Taylor Hayes, the managing editor for Clinics in Geriatric Medicine here at Elsevier. Clinics in Geriatric Medicine is a quarterly publication consisting of review articles focused on a central topic related to geriatrics. Today, we will be discussing the recent August 2023 issue dedicated to palliative care, guest edited by Dr. Kimberly Kursine. Here with me today are Dr. Sarah Cross and Dr. Dio Cavaliertos, who wrote an article on public health and palliative care for this issue. Dr. Sarah Cross is an instructor in the Division of Palliative Medicine and Division of Family and Preventative Medicine at Emory University School of Medicine. Her work has been published in peer-reviewed journals such as the New England Journal of Medicine, JAMA, and the Journal of the American College of Cardiology. She's also been covered by media outlets including the New York Times, the Washington Post, Reuters, and NPR. Prior to pursuing her PhD in public policy from Duke University, Dr. Cross was a social worker in home hospice and inpatient palliative care. She saw up close the limits of existing palliative care and hospice service during her time as a social worker. Her current research priorities are identifying, understanding, and improving the experiences of people facing structural inequities at the end of life. Dr. Dio Cavaliertos is Associate Professor and Director of Research and Quality for the Division of Palliative Care within the Department of Family and Preventative Medicine at Emory University. He is a health services researcher whose work focuses on development, evaluation, and implementation of models of palliative care delivery in serious chronic illness. His work has been supported by a variety of public and private sources, including the National Palliative Care Research Center, AHRQ, the Cystic Fibrosis Foundation, and the National Heart, Blood, and Lung Institute. His research has appeared in journals such as JAMA, the Journal of the American College of Cardiology, the Journal of the American Heart Association, CHEST, and others. His work has been featured or he has been quoted by media outlets including the New York Times, Reuters, and STAT. Welcome to the podcast. Thank you for joining me today. I'd like to jump right into the first question and ask if you could explain to me what palliative care is.
Well, first, thanks for having us. I'm glad to be here to talk about this. Often, palliative care has been described as a specialized type of care for people with serious illness. That can leave out a lot of details. So one of the things that I did want to emphasize is the holistic nature of palliative care, that when people do have serious illness, they often have needs far beyond just physical. And so palliative care addresses suffering that's emotional, psychosocial, financial, spiritual, in addition to just the physical needs. And when we look at hospice, hospice is a type of palliative care, but palliative care and hospice are two distinct services.
Can you please tell me a little more about hospice?
Inpatient hospice is part of the existing hospice benefit. You have to justify need based on your symptoms because Medicare reimburses it at a higher rate. And so they're careful that that is not abused. There are, I think, some concerns about people needing intense care when they're not able to have it done well at home. And those Medicare regulations are often a barrier because someone may have, say, caregiver issues and they need a safe place to go, or Medicare may not pay for it longer. And so there's some particular sort of nuances in the policy, but it's more that we need to figure out how to sort of widen access, and therefore, how are we going to pay for that widened access? It's figuring out how do we adapt and evolve the hospice benefit. And the right way to do that is sort of still an unanswered question. There are different people who have different opinions about whether we, adapt what we have or we go back to the drawing board and create something new. But as far as different models of care, been a newer push to try to get home-based palliative care. And when I was last working as a palliative care social worker, there were some hospices who had, for example, what they called an open access program, that they would be able to pay for the additional services that a patient needed as a result of donations that they had received. And so it can be a hit or miss situation. Is where do you live? Is there a hospice that is able to do this, quote, open access program and give you services when you're not strictly meeting hospice criteria? So it's really, are you fortunate to live in an area where this is up and running currently? And many people in the country are not.
And how did you both end up in this field?
This is what I've done for the duration. It was my first job as a social worker. I knew I wanted to work in the area of health, didn't know what exactly. And to be honest, when I first started working in hospice, I had no clue that I would still be doing it, more than a decade later. It was just something that once I started working in, I realized how much I loved it. And soon after, my grandmother died, and I saw how much it mattered to get people quality care. And I've just ended up spending the rest of my career in it.
I think a lot of us in palliative care oftentimes have a personal story that ties us to the field. Palliative care is something that often people get into lightly or flippantly. For me, it was experiencing serious illness and death amongst family members when I was younger, and then, thinking about how can I be involved in healthcare. And while I initially thought about, the traditional path of thinking about med school and whatnot, I wondered about how we could improve serious illness care from a population perspective, and thinking about the science and the evidence behind it, which is how I ended up pursuing the route of more of a clinical investigator in palliative care.
I also wanted to talk about your article, which was found in the August issue. And you stated in this article that end-of-life care is a public health concern, yet a public health approach has not been widely applied to end-of-life care. Do you mind clarifying what you mean by that and why you think that's needed?
If you use, for example, look what we've just all been going through with the COVID pandemic, and we have education about vaccines. We have education about smoking, and smoking is bad for your health. We have education campaigns about safe sex. We don't do the same thing when it comes to preparing for serious illness or end of life. And some of that is just our reluctance to talk about this issue as a society. And so we tend to deal with it when there's a crisis. We don't have the foresight often to plan ahead, to talk about what do you want your care to look like should you develop a serious illness. And so there's a lot of sort of waiting for a crisis to prompt these sort of conversations. And I think one of the other benefits of the public health lens is this whole concept of prevention and trying to mitigate the suffering that is likely to arise rather than just trying to figure out how to put out fires at the last minute.
Exactly. I think Sarah said that perfectly right. So thinking about how do we set up systems in place to prevent preventable crises and to prepare people, but then it's also thinking about how do we optimize current systems, whether that's how we sort of structure and where we locate palliative care services, for example, to maximize the needs of populations, how we build in technology and then evaluate it. All of those things very much lend themselves to a public health approach. And so I think that is one perspective that has been pretty lacking, at least in the US, and how we think about palliative and end-of-life care. Taken a public health approach and done it really well for a number of other concerns. For example, I'm thinking about like dental public health. I'm thinking about cancer screening, for example. But we really haven't taken that approach to serious illness. And I think, again, with the aging population, I think it's long overdue that we start thinking about things from a systems perspective.
And in addition, thinking of how to provide care in different settings. So often we're talking about palliative care in the hospital, or we're talking about hospice at home, but people live in nursing facilities and in assisted living. And so figuring out the care models that also incorporate that into the payment and the services is going to be essential as well. I think oftentimes in the clinical realm, we deal with situations as they arise individually. We have a patient with these needs. We go to another patient, they have these needs. And one of the things that I think that we have failed to do is to address serious illness needs at the population level. Some of that is due to the design of our healthcare system. Some countries have done a better job where they have universal healthcare. They have different types of services. They have less separation between health and social care. But for a multitude of reasons, we haven't looked at this as a population level public health issue. We've kept it in the world of clinical medicine, clinical care, where we're sort of trying to put Band-Aids on situations as they arise, rather than creating the infrastructure to be able to make sure that care is accessible by everyone who needs it.
Are there any different approaches that you would take for someone who is maybe in a rural setting? Are there any considerations that you make when planning for end-of-life care based on geographical location?
Well, one thing that I can say from my experience as a social worker is that some services may be more difficult to obtain in rural settings. That's not always the case, but if we can talk for a second about inpatient hospice, that's one example. So inpatient hospice facilities are typically freestanding sort of hospice houses where someone can go for a very short period of time if they need intense symptom management. Those are not widely available geographically. There is a disparity in where those are located. And so some people in rural settings may be disadvantaged if that is a level of care that they need. We've also seen closures of rural hospitals and nursing homes in rural communities. There are fewer just hospice agencies, home health agencies in rural areas. That is a gap that we need to study and address. There are also some fabulous hospice providers in rural areas. And so I'm not making an across the board statement, but just the cost of putting an agency or an organization in a rural area and staffing it. There are limitations that then affect the care that you're able to provide in a particular area.
And are you optimistic that we can ultimately develop a public health approach to palliative care?
I don't think we would be doing this work if we didn't think that some changes could occur and that eventually we can get closer to the goals that we have. One of the key barriers is letting money and costs drive how we deliver care and what those services are. And I think that until we care more about ensuring that everyone gets the care that they need and that they deserve when they have serious illness or when they are nearing the end of life, we're going to fall short of that. And so that needs to be the priority rather than trying to save money or trying to figure out how to make money, from one end or the other. And we talk about that some in the paper, how the way that hospice was designed to save costs has actually ended up harming a lot of people because of the way the policy has ended up.
I think the other thing I'll add, and building off of what Sarah mentioned in her last comment about sort of Band-Aids in the system, I too am optimistic, right? Again, like what Sarah said, we wouldn't be doing this day to day if we didn't think that changes could occur. I do think, though, that our approach even still has continued to be a band-aided approach. And where the optimism truly lies in me is if we can hold out for some massive systems level redesign that fundamentally shakes up how we think about health and illness, right? So Sarah mentioned earlier about the sort of the ties between healthcare and social care. That, for example, plays out really prominently in a lot of palliative care encounters, right? A palliative care clinician might work with a patient individually to sort of stabilize them in the moment, take care of their concerns in the moment, and then we send them out to their lived experience where they might be facing X, Y, and Z social and structural barriers or disadvantages. And yet we as a healthcare system, one, you might ask yourself, what is our role and what power do we have outside of the clinical encounter to modify some of those situations that could land that person back up in the hospital, or even if they don't end up back in the hospital, perhaps some of those barriers do constrain some of the options that somebody might have during the serious illness experience, where they receive their care, what kind of support they have around them. Are they able to afford the medications and the other services that they need to keep them comfortable and have the best quality of life? So I think to answer your question again about optimism, I think I personally have optimism, and I'm holding out hope for a massive redesign so that we can stop band-aiding here and there.
How does the current form of hospice impact patients with diagnoses such as heart failure and dementia?
When I mentioned that the way that hospice is currently set up, it was designed based on the needs of patients with cancer who have a disease trajectory that's different from, say, heart failure or dementia, where typically it's pretty obvious when someone gets to that quote terminal phase. Although it's a little trickier now with advances even in oncological treatment, there's less of a clear cut of when is this treatment no longer going to stop or cure, cancer, for example. And so it was more obvious about when was appropriate to cease that type of treatment and focus on the comfort treatment, the comfort care, hospice. With a disease like heart failure, the disease trajectory is quite different. And so hospice currently requires that a physician say, I think you likely have 6 months or less to live. It's a lot harder to prognosticate in heart failure. And so knowing when to bring hospice in is less clear, both for the clinician and for the patient. The patient may not be aware that they're dying because they can get their symptoms managed and feel so much better. And so they're not able to sort of prepare or to see changes in the same way that someone with terminal cancer might. So that, just looking at the disease specific issue, is where the limitations arise. The policy just doesn't fit the needs of other diseases as well as it initially fit those with cancer.
And for the seriously ill patients who are ineligible or do not want hospice care outside of inpatient settings, what can you recommend for them?
And we didn't talk about that as much in the paper, just, given the limitations, but because hospice kind of started first. And so the non-hospice palliative care really developed more after hospice, in part due to people seeing the limitations, that there was a large population who may not have qualified for hospice, but still had significant needs that needed attention. And so there's been this gradual growth in upstream palliative care. And most of that care is provided in the hospital setting. We are currently not widely available when it comes to home-based palliative care. That's something that's growing, but figuring out how you pay for that, what do insurers cover, who's going to deliver that? Does that come out of hospice? Does that come out of home health? So these system-level changes that Dio referenced earlier are applicable here too when it comes to non-hospice forms of palliative care. And so it's going to take overhauling and creating new models of care to ensure that those people also get their needs met.
Minoritized individuals and individuals of lower socioeconomic status might not qualify for hospice and are therefore particularly disadvantaged by the existing hospice policies. How does the current form of Medicare hospice contribute to racial and socioeconomic disparities?
We know from research that has been conducted that racially minoritized people do use hospice at lower rates, and that can be due to mistrust, understandable mistrust of the medical system. It can be related to cultural or religious beliefs. But going back to the way that hospice is designed currently, when you force people to make a choice between one type of care versus another, it makes total sense that populations who have previously been denied care might be wary. And not only people who've been denied care, but even, people who have had access to care throughout their history. But it's a very emotional decision to make. And so you can't exclude all of the other factors that someone may have experienced up to that point. But ensuring that we deliver care that takes into consideration people's preferences and people's cultures as much as possible is going to be increasingly important, particularly the aging population.
Yeah, and I think to build off of that, I think we will see attention being paid to having sort of personalized care and watching people's identities inform the care that they receive. I think we'll see that grow more and more, both from a clinical perspective as well as hopefully from a policy perspective too. As we've talked about, the Medicare hospice benefit tends to be a bit one size fits all. And that can't take into account the variety of nuance that exists in people's wishes and their preferences that are informed by their identities and their cultures. And so I think, and I hope that we will see some flexibility in new models of care that allow for that nuance.
And Dio, speaking of that flexibility, one of the issues that we're both passionate about is the socioeconomic disparities, that when you have a model of care that it requires that the family be responsible for the bulk of care. If someone doesn't have family, or if someone has family who has to work or has children or has other demands, or they don't have the financial resources to support staying at home, how is that going to work as well as it does for someone who has available family to sit, or, someone who can go do errands or help around the house? And so part of the disparities that we see in where people die are rooted in that socioeconomic disparity. And so figuring out, like Dio said, how to get care more tailored to the real life situation of someone who is seriously ill or dying, figuring out how to plug in holes in the system, connect the health system with the social services so that people don't fall through the cracks and end up getting care that is contrary to their preferences, such as going back to the hospital if that is not what they wanted or it's not necessary. So there's a lot of work to be done.
Yeah, so to build off of what Sarah was saying, I think, we've talked a lot about racial and ethnic-based disparities. We've talked about socioeconomic disparities. For example, there are other facets to people's identities that could lead them to be in a circumstance where, for example, the Medicare hospice benefit might not work for them. One population I'm thinking about in particular, one of our investigators on our team here at Emory University, who's looking a lot at this population, is those who are aging solo. Those who are aging without close caregivers, whether that be family or friends. And so, individuals who fall in those circumstances, whether that's because of, being widowed or never in a partnership, whatever that may be, how do those individuals go through the serious illness experience when, for example, many hospice organizations might not accept you onto their service if you don't have somebody at home to care for you around the clock? What do we do for those individuals who will inevitably and are already falling through the cracks? So again, I think we need to take an approach that sort of looks at individuals at all of their facets of their identity and allows us to pick and choose the services and how those services are delivered to meet that individual's needs. Dr. Jane Lowers here at Emory University, one of the subgroups that she looks at in particular are people who are LGBTQ identifying. I think, again, just like we're talking about all of these other facets of someone's identity, whether it's their socioeconomic status, whether it is their social support system, whether it is their racial and ethnic background, their religious preferences, whatever that facet of their identity may come with certain considerations, right? And so I think meet the person where they're at, identify who that person is and what matters most to them, and what are the parts of their identity that we need to think about customizing their care for. And then the things that we need to keep in mind, again, are social support systems, any past history of trauma, for example, any sort of considerations about decision-making, who they'd want to make their decisions for them. These are considerations that we would take for any population.
We are not saying that people from one particular group are naturally all going to have the same preferences or want the same types of care. And so I want to be intentional about saying, I don't think that any group, should have care designed in one particular way. So like Dio said, take those things into consideration, but personalize it. We've been living with this one size fits all hospice policy, and sort of what Medicare does, Medicaid and private insurance follows. And so most people are limited by the design of that Medicare hospice benefit. There's some question about, do we want disease-specific hospice benefits that take into account the differences in the disease trajectory, the differences of the clinical needs that someone might have? Is a symptom flare-up likely to have someone go back to the hospital? How do we manage those when they may be different for a disease versus another without forcing somebody to give up hospice if that is working well for them and meeting their needs? And so I think what we really need is flexibility that meets patients' needs and not having this cost containment drive the way that we're currently delivering care.
And where do you predict palliative care will be in the next few years?
Like Dio said, those of us who are doing this research, and we obviously are coming behind people who have been dedicated to this area and to this field and who have been doing research to try to improve care for those with serious illness. And so there is a growing pool of researchers and clinicians who are committed to this. I think one of the barriers is going to be, getting change through the political system, new laws and looking at all of that. But I do think we're making progress. And so you see efforts. PACHITA, for example, is legislation that's been proposed that expands the palliative care workforce. And so they're increasing efforts to try to come up with these new models of care. So I think that in the next several years, we're going to be seeing these changes. Unfortunately, there are a lot of people who need care whose needs aren't going to be met until those things come into play. But I think we're moving in the right direction. We need a lot more funding from research bodies to get this done. And we need more people in the workforce, both as clinicians and as researchers. But I think we'll get there.
Yeah, and I think to build off of that, I would agree with Sarah that the political climate and what we're able to get through on a policy level will definitely make an impact. I also think that we'll see palliative care services be a bit more, if I may, smart in sort of how they leverage themselves through healthcare systems. So what are the indications for which they are most consulted? How do they function with other service lines? Basically optimizing the limited workforce that we have so that we have the maximum benefit across the system. I think we'll also see technology make its way even further into palliative care. The pandemic showed us what we can and can't do in terms of telepalliative care. I think we'll be seeing telemedicine in palliative care expand even more with time. I think we'll see other technological innovations coming through, whether that's AI and other technologies as well. Again, to just optimize the efficiency and the effectiveness of palliative care services.
You mentioned lessons that have been learned from the pandemic. I think in addition to what he mentioned, where people get care may shift. I think due to the dangers of being in the hospital and the risk of catching COVID, for example, not just hospitals, but in nursing homes, there's been a bit of a shift to get more care delivered at home. You've seen news articles, for example, on hospital at home models of care. And so I do think that has prompted some push to try to update and figure out how to improve services that are delivered to people in the home. So I think that may be another trend as well.
Thanks so much for taking the time to speak with me today. And thank you to our listeners for joining us for this edition of the Clinics Review Articles podcast series. We hope this issue and podcast was helpful. For an exclusive discount on the issue we discussed today, focusing on palliative care, visit us.elsevierhealth.com/expert. Clinics in Geriatric Medicine is available for individual print subscription with accompanying online access, as well as individual online-only access, and is also available on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 65 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter @Clinics Reviews and subscribe to the Clinics Review Articles podcast wherever you get your podcasts. Thanks for listening.